Hello, I'm Eric Garcia. I'm a nurse practitioner student at UTEP for the Acute Care and Adult Geriatric Nurse Practitioner program. This semester we are rounding with acute and critical illness, and I was able to more or less admit a patient into the ICU. Pretty complex patient, so I'll go over with all the points on the rubric with you guys. This is a 70-year-old Hispanic male. He was previously at Del Sol for sepsis. He has a non-healing diabetic ulcer that required a right BKA, and he received this at Del Sol. He has severe PVD as well as complications from diabetes, so this is not a cutaneous ulcer from pressure. He developed gastric ulcers as well from stress at this previous hospitalization. Upon arrival to our facility, he did have recurrent bleeding. That was his main complaint, was hemoptysis. He was also found to be hypotensive and tachycardic, showing signs of early refractory sepsis due to the right BKA, which is not healing very well. He was received from a LTAC where he was receiving wound care and management, which is who brought him into the hospital. It appears that his gastric ulcers have begun bleeding again. His common history includes severe PAD with multiple angioplasty procedures, status bilateral knee amputations, below knee amputations, chronic kidney disease, stage 4, requiring dialysis, long-standing diabetes, mellitus type 2, insulin dependent, hypertension, hyperlipidemia, recent seizure disorder, atrial fibrillation, which he is being treated with amiodarone, congestive heart failure with an estimated ejection fraction of 25 to 30%, which was just obtained this visit, recent and recurrent upper GI bleeding from stress-induced gastritis, along with post-hemorrhagic anemia, obviously, which has required multiple units of PRBCs. He has received 2 since admission here, and we are continuing to monitor his H&H, which I will further elaborate later. Surgical history does include, as I mentioned, the bilateral below knee amputation, gastrostomy tube placement, which was placed in November of last year. He also has a PEG tube placement, which has been removed, which was done April of last year. And the surgical and wound treating of his right BKA, which is the most recent one that became infected. He's also had a tubal angioplasty procedures. His physical presentation was pretty much lethargic, almost unresponsive. He was experiencing hemoptysis, as previously mentioned, altered mental status, and hypotension. His diagnostic workup was an MRI of his right BKA, which was negative for osteomyelitis, but did appear to be infected with redness and pus, green pus oozing out. We also obtained a CBC and a CMP. He did have elevated lactic acid. He was anemic, elevated BUN and creatinine, obviously. Ultrasound was done due to extremity swelling, the upper and lower extremities, which we did find positive for right axillary vein DVT. Echocardiogram was also obtained, which is positive for congestive heart failure as well as a right atrial thrombus. Due to the bleeding, we haven't been able to continue any anticoagulation to prevent any further thrombosis. So management was to admit the patient to the ICU, cross-match, transfuse 2 PRBCs for the time being, and to keep the H&H above 8, checking every 6 hours. His admission H&H was 5.2 and 16.1. If his H&H remains stable for 24 hours, we will reduce spot checks to Q12 hours. He is not a candidate for a blood thinner, as I previously mentioned, due to his obviously acute bleeding. I will consult, or I did consult, interventional cardiology for possible thrombectomy. A GI consultation was also placed for the bleed and the gastric ulcer management, as well as his PEG tube. IR consultation was placed for possible embolization of the bleeding vessel inside his from the gastritis as well, so they can work with GI. Intensivist was also consulted to manage ICU care. He's been placed on a protonic strip, nothing by mouth. Pressors can be started as needed following hospital protocol. He did have recurrent AFib RVR upon admission, likely due from the hemoptysis, anemia, and heart strain, so it is being controlled right now with amiodarone drip and PRN metoprolol, which has improved since the blood transfusions. His overall prognosis is grim. Infectious disease consult was placed again for antibiotic management as well as wound care. They have also been consulted to work hand in hand with infectious disease. All oral meds that are necessary will be given via his PEG tube. Short-term complications are going to be from no anticoagulation, as we've already established from the thrombus he has obtained. Bleeding is still a complication. He can continue to bleed again. Cardiac complications such as MI and infarct from the atrial thrombus, pulmonary embolism, stroke, AFib with RVR, which did happen and is being controlled now, but we can't rule it out that it won't happen again. Infection and wound healing is still an issue, but a little bit more long term. We will plan on admitting him back to an LTAC once we have stabilized him here in the hospital. Family members have been consulted. They do not seem open to any end-of-life decisions right now, although they have been, I guess you could say, prodded and explored, but there was pushback. He will continue to need hemodialysis long-term, and again, prognosis is grim. He will need continuing therapy at an LTAC for foreseeable future, as well as a sniff after that, probably, as he is basically total care and would be very stressful for his family. He has improved in recent days in regards to pressors, heart rate, and mentation, but still needs some work here in the hospital before we can transfer him to an LTAC. And that's about it. Thank you very much.